Hello, we're going to be talking about popliteal and ankle blocks today with Baskar. We have a chat session right now, and then we'll move on to scanning in a minute. So, what is the anatomy behind the popliteal sciatic block?
The popliteal sciatic nerve is we're doing the sciatic nerve at the level of the popliteal fossa. The sciatic nerve itself originates from the sacral plexus, from the ventral rami of L4 to S2 nerves, and they come out of the greater sciatic foramen. They run between the lesser trochanter and the ischial tuberosity, and it just runs along the thigh muscles, and we are targeting them at the popliteal fossa, so we call them as popliteal sciatic nerve block. So there, the popliteal sciatic nerve actually divides into common peroneal and tibial nerve. That's the level where it kind of takes off in different directions. So they're between this kind of four different groups of muscles which form the boundary of the popliteal fossa. It is on the lateral side on the top. You see, have the biceps femoris on the lateral side and the semimembranosus, semitendinosus on the medial side. And below on the other side, you have the gastrocnemius muscles forming like a nice quadrangular space. And within that space, you have the popliteal sciatic nerve and the popliteal artery and the vein with a pad of fat around it. So it's a very easy access point because there's no muscles covering it. The nerves can be easily blocked at that level. So the nerve itself has got quite a tough sheath around it, which it takes on from the surrounding muscles. So although it's one nerve, even from the top of the thigh, it is like common peroneal and tibial nerve run alongside one paraneural sheath. So it's very important that we put the local anesthetic inside the paraneural sheath. We are not intraneural. It's not inside the epinudium of the nerve itself, but there is a sheath that covers both common peroneal and tibial nerve, and that's where we're trying to target the local anesthetic.
Okay. So based on the territories of the sciatic nerve, what are the most common indications?
Because we're blocking it at the level of the popliteal fossa, it can be used for any surgeries below the popliteal fossa, which is any operations on the leg or the ankle or the foot. The sciatic nerve is the main component of the sensory and motor supply for the lower leg, and the only exemption being the medial surface of the leg, which is supplied by the saphenous nerve, which takes its contribution from the femoral nerve. The femoral nerve continues as the saphenous nerve below the knee. So that supplies mainly the skin, and it's a sensory nerve, but predominant motor and sensory supply for the osteotomes, for the myotomes, and for the skin, it comes from the sciatic nerve. There's only one exemption, which is the posterior femoral cutaneous nerve, which could supply a bit of the back of the leg, but we don't normally block them, but it is possible to block it higher up in the subgluteal region. But it is the main nerve that supplies the lower leg. So for any surgeries in the ankle or the foot or the lower leg, this is the preferred block or the most important block that we need to do.
Okay, so I'm sure you're going to talk about this whilst you're scanning, but
Yes.
How would you position the patient for popliteal block?
Yes, we will see that in the workshop where we do a live demonstration, but the most common preferred kind of positioning of the patient is prone, because it's very easy access. You can see the surface anatomy clearly, but in a patient who can't turn prone or has got fractures and plasters or on a traction table, you could do them with the patient supine, with the leg lifted up on some kind of a support. So you place the probe from underneath and you can block the nerve from a lateral approach. It's possible to lie them on the side as well for patients who can turn on the side. So you put the leg that you're going to block on the top, because the nerves are mostly on the lateral side. So the leg that needs to be blocked has to be on the top. So, and then you again do the same approach. The scanning is exactly the same, irrespective of which positions you place. And we will see that in the live demonstration.
Sure. How much would you inject, and any practical or technical tips?
Yes, we try and avoid local anesthetics which with adrenaline, because the sciatic nerve itself has got very limited blood supply, so the blocks can last longer, and the patients generally, because of the motor block, they can have a foot drop. As you see in the video here, you see the needle is inserted into the paraneural sheath, and you're aiming for the local anesthetic spread around both common peroneal and tibial nerve, which is nicely illustrated on that video. So you have this kind of a double fried egg appearance where both nerves are soaked up in the local anesthetic. But we tend to use about 10 to 15 mL of local. If you can avoid adrenaline, that is better to avoid a prolonged block. But 10 to 15 mL adequate volume for a popliteal sciatic nerve.
Okay. And finally, what would you say is the difference between a popliteal and an ankle block?
The ankle block is something we do for foot surgery. It just kind of blocks below the level of the ankle, so it's not suitable for an ankle surgery in itself, because you're targeting the terminal nerves which come out of the sciatic nerve. So they're very useful for a big toe surgery, second toe, that sort of toe surgeries, or the forefoot surgeries, to be honest. But the ankle block itself doesn't provide a kind of good tourniquet tolerance, because whether you do a ankle tourniquet, even with the ankle tourniquet, you can feel pain after 20, 30, 25 minutes, because it can be quite excruciatingly painful. So if you're doing it as an anesthetic technique, ankle blocks are suitable for foot surgery, forefoot surgeries without a tourniquet. But whereas a popliteal sciatic nerve block can be used as an anesthetic as well as an analgesic for any ankle surgery or lower leg surgeries.
Brilliant. Thank you very much.